See, I'll tell you something which is very interesting. I don't know whether other speakers on your show have given you this information, but I endoscope almost 100% of my patient, both pre and post operatively. So we have a busy bariatric endoscopy program, and we have fellows from across the world, and we endoscope most of our patients, I would say, after mini gastric bypass. So I have a lot of information on what you are talking about. Now, my concern is not bile reflux into the gastric pouch. A bile reflux into the gastric pouch is very common and it can happen. And it's not of a concern to me because when I do endoscopy on normal individuals who do not have who do not have an anatomy of bariatric surgery, even they have bile in their stomach. So if I do endoscopy, almost 30 to 40% of these patients will have bile in stomach without any bariatric anatomy like one anastomosis or gastric bypass or whatever. But when we do endoscopy in mini gastric bypass, again 30 to 40% of the patients will have bile in the esophagus. Now that is not my concern. Bile in the stomach, pardon me.
Yeah.
Bile in the stomach is not my concern. My concern is bile in the esophagus. Now, bile in the esophagus is not going to come in patients in a routine way. This will be there only in patients who have some problem with their lower esophageal sphincter. So the issue is that the LES sphincter and the mechanism of the LES sphincter is not understood by many surgeons. And that's why they keep on offering wrong surgical procedure. So for example, you have a patient who has a history of gastroesophageal reflux. That is not a disease of stomach or the disease or the outcome of a bariatric procedure. That is because he has a defective lower esophageal sphincter. Now, if preoperatively you can diagnose and eliminate these patients who have a defective lower esophageal sphincter because of multiple reasons. It may be because they are obese, first of all. It may be because they have a smaller length of intra-abdominal esophagus, which is minimum of around 2 centimeters, but they have lesser length. It's because they might have a hiatus hernia, or it's because of unknown mechanisms. And somehow, if you are able to rule out the patients who have this defective LES, which can give rise or which is giving rise to a reflux even before surgery, I would never offer a mini gastric bypass to these patients. So my concept is very simple. We have an algorithm at our center. We do 3 surgeries: sleeve, conventional gastric bypass, and a mini gastric bypass. Now, we have a very simple algorithm to decide which patient will get a sleeve, which patient will get a OY gastric bypass, and which patient will get a mini gastric bypass. So for all those patients who have a defective lower esophageal sphincter, we would never offer them one anastomosis gastric bypass, because there we have the concern of this bile going into the esophagus. And the studies have shown, at least the rat studies, and there are some in human which have shown that bile is a carcinogenic agent and it can cause issues with the lower end of the esophagus. But rest, for all other patients who do not have a LES issue, I'm not concerned about bile reflux.